general chest exam. Be sure to wash your hands prior to any physical exam. For the chest exam, have the patient gowned or loosely dressed. Always examine sequentially from side to side. Maneuver the gown for optimal access and view. Inspect the chest to approximate the location of the horizontal, right oblique, and left oblique fissures. These separate the upper lobes, middle lobe, and lower lobes of the lung. Be aware of the location of these lobes on the lateral surfaces. Also note that on the back of the chest, the lower lobes take up most of the space. Look for asymmetry and deformity of the chest wall. Inspect for deviation of the trachea. Also, observe the rate, rhythm, depth, and effort of breathing. Observe the AP diameter. Although not present in this patient, an increased diameter or barrel chest may indicate respiratory disease. Palpate several areas on the anterior, posterior, and lateral chest. Ask the patient to identify any areas of tenderness. Remember to always examine sequentially from side to side for comparison. For proper percussion, place the distal middle finger firmly against the chest, positioning it between the ribs. Tap smartly with the opposite middle finger on the middle phalange, producing a good percussion note. Percuss 6 points anteriorly, beginning with the apex. You will also percuss at least 1 point on each side and 4 points posteriorly. Always remember the underlying anatomy to identify the lobes of the lung you are assessing. Note that an increase in dullness may indicate masses or fluid in the lungs, while an increase in tympany may indicate a pneumothorax. Always remember to examine both sides sequentially. When percussing over the back, for a clear sound, make sure you avoid percussing directly over the scapulae. Auscultate a minimum of 6 points anteriorly, with the diaphragm beginning with the apex. The bell may fit more comfortably over the apex. Be sure to press down firmly so that it functions as a diaphragm. When auscultating, ask the patient to take a deep breath. Again, remember the underlying anatomy to identify the lobes of the lungs you are assessing. You will also auscultate 1 lateral point bilaterally and 4 posterior points. Be able to articulate a description of rales or crackles, wheezes, or rhonchi. Also understand the significance of an abnormal inspiration to expiration ratio. In some pathologic states, lungs lose some of their elastic recoil, and expiration time may be prolonged. The peak flow monitor is a simple tool used to measure the patient's forced expiratory volume in 1 second, or FEV1. Always use a clean mouthpiece for each patient. Recalibrate down to 0 before each use. Have the patient stand up. Instruct the patient to seal his or her mouth tightly around the mouthpiece. Inhale, and then expire as quickly and forcefully as possible. Note the reading and recalibrate back to 0. Have the patient repeat this 3 times and record the highest value. To assess chest expansion, place your thumbs at about the level of the 10th rib, with your fingers positioned as shown. Ask the patient to inhale deeply and note the distance and symmetry of movement between your thumbs. Asymmetric movement may indicate underlying unilateral pathology. The test for tactile fremitus assesses the transmission of vibrations, or fremitus, to the chest wall. Using the ball of your hand, press firmly in the interscapular space and ask the patient to repeat the word 99. Identify areas of increased or decreased vibrations. Alternately, you may use the side of your hands rather than the balls of your hands. This is used as a rough screening for air, fluid, or masses in the lung. The test for diaphragmatic excursion evaluates whether or not the diaphragm is moving properly during inspiration. Begin percussing above the expected level of the diaphragm and percuss downwards until tympany changes to dullness. Note this location. Now, ask the patient to hold inspiration and from the previous point, percuss downwards to the new level of dullness. The distance between these points represents the distance the diaphragm moved. The test for egophony assesses transmitted voice sounds. Place the diaphragm of the stethoscope firmly on the chest wall and ask the patient to say and sustain the letter E. In some pathologic conditions, the E may transmit as a nasally A sound. This E to A transition is known as egophony. You must keep special considerations in mind when performing a respiratory exam on a female. Respect her modesty and keep her covered as much as possible while still performing the exam properly. She should be gowned without a bra for proper examination. Lower the gown as necessary for inspection and palpation. It is generally appropriate to ask your patient to help maneuver the gown. Ask the patient to lift the gown and her breasts when you need to palpate, auscultate, percuss, and inspect the lower thorax. Although you should attempt to keep the patient covered as much as possible, never examine over the gown. Please see the general chest exam for proper technique of a thorough exam. This section is only a guide for maneuvering the gown around a female patient.